And it's good to see that the Europeans are finally recognizing that systemic progesterone has a point. But I think I have no conflicts, and I want to start sort of the same place that Peter aren't aware of these early studies, but when they started doing embryo transfers with so knowing that, and then we talk about measuring progesterone. And so I think, as Dr. Humadan mentioned, it turns out that there's something more important than just the endometrium or just what the progesterone level at the endometrium is. But all of these studies where they looked at low levels that were rescued by starting progesterone on the day of transfer were with vaginal progesterone. In that intramuscular study by Kate Devine, there were only about 3% of the patients who were on the daily intramuscular and about 9.5% of those who were on the every 3-day intramuscular who fell below a cutoff of 9 nanograms per ml. And of those patients, 43% became pregnant. So the question is it really still important to measure progesterone when you're giving intramuscular? Well, I want to ask again about the vaginal, and why are pregnancy rates lower if endometrial tissue levels are higher, and why are they rescued when you give additional progesterone? And I think the facts that Dr. Humadan was talking about in terms of what else is progesterone doing, and are there other factors? Are there additional benefits of these higher progesterone, particularly in terms of immune modulation, in terms of decreased uterine contractility? There have been some of the studies that have been done in Canada where they've looked at uterine contractility, and it appears to be less with intramuscular. And this is just kind of an interesting, it wasn't why we were doing the study, but we were doing the study to look at endometrial biopsy. One of my colleagues, David Huang, who is doing single-cell seq, was looking at a huge swing toward natural cycles. We can discuss whether that's a pro or a con, but there's been a huge swing toward natural cycles. And again, if you go back to very basic data, this is old Sam Yen data, and you look at daily hormone levels, you see this dramatic rise in progesterone after the onset of the LH surge, and by 36 hours after natural cycle. And we think about how do we time a natural cycle to make sure that we've got the embryo. Very old data from France, over 1,000 women who themselves, partners were sterile, they were getting donor inseminations, and there were no pregnancies if the dominant follicle was less than 18 millimeters at the time of ovulation. Now granted, in this study, you're counting on the egg to cause that pregnancy, and you probably need a certain amount of maturation. But I would argue that the egg and the somatic cells, the granulosa cells, are communicating with each other. And I don't know that not having that 18 millimeter maturation of the egg, but also maturation of the follicle unit itself, may not be important. There have been recent studies that looked in natural cycle the importance of estradiol, and they come up pretty closely. The Romansky study said you needed at least 100 picograms per ml for 4 days, and Ellsberg that you needed at least a level of, I think, 9.6 or 96 by day 10. And so the importance of that estradiol level, and let me tell you now, all my partners decided not only should they measure progesterone to see when it gets above 3, but now they need to measure follicular phase estrogen. And then recently, importance of follicular collapse. So all these aspects, if we're going to do natural cycle, all these aspects of the follicular phase are going to help us determine if our luteal phase will be adequate. Well, I decided, since we talk about PGT 1.0 and PGT 2.0, I'd talk about natural cycle FET 1.0. And in the old days, we were very simple. we had to have a follicle above 18, at least 18, because of the Seacoast data. Patients used urinary LH monitoring in the evening, because usually people will surge in the middle of the night around 1 o'clock. It takes about 12 hours to get to the urine, so if you test in the morning, you might miss it. And then we confirmed within 2 days that there was a collapse. That was it. Didn't measure estradiols, didn't measure LH, didn't measure progesterone, didn't HCG trigger, didn't supplement with progesterone. The caveat was these were young women who had regular cycles. And what has happened is we've started to open, because we've decided natural cycle is so important, we have now expanded it. And is that really the right thing to do? And if we're going to expand it to these women who might not have a normal cycle, should we measure progesterone? If we measure it, what level? The excellent studies from Copenhagen, what level is adequate? And I share this same slide that Dr. Hamilton did that shows you in this one patient that dramatic variability in progesterone across a 24-hour period. And so the option came up, well, why don't we just supplement in everybody? And so this is vaginal progesterone in the natural cycle. And in all of these studies, and these were largely cleavage transfer studies, because you can see they're older, some blastocyst transfer. And interestingly, the progesterone, whether it was a day 2 transfer, a day 3 transfer, or day 5 transfer, the progesterone wasn't started until the day of transfer. But what you can see is whether you supplemented in the gray or you didn't supplement in the blue, it looked like the pregnancy rates were higher with supplementation. Well, why might that make sense? And as I said, we have expanded to utilize natural cycle in people that 10, 15, 20 years ago, we would not have used their cycle because we didn't think that they were normal. And one example of that is women who are older. And this was a population of women, and this is the younger women are 25 to 35, the older women are 35 to 45. And they collected daily urinary metabolites. And these were all women who had regular cycles, reported no change in their menstrual cycles, but what you see is the older women make about half as much progesterone as the younger women. So maybe if we're going to expand natural cycles to everyone, we need to just add the supplemental progesterone. Well, one of the other problems with the way natural cycles are done now is they require frequent ultrasounds, and ideally they require normal cycles. And so there have been attempts to increase convenience both for the clinic and for the patient, and to compensate for these minor ovulatory dysfunctions so we could include in those people having a natural cycle versus a programmed cycle and be able to utilize, mainly in the US, so people could avoid intramuscular, but also some thought that natural cycle may be better. Well, what about the addition of HCG? And in this study by Metkins, there was no difference in pregnancy rate if there was a natural surge or there was an HCG. But if we're talking about convenience, the patients who got triggered by HCG had less visits, and so it was more convenient for the patients. Now, there were a lot of patients that ovulated spontaneously before they took the trigger. And so if you're going to do that, you need to decide again at what level, at what size follicle will you trigger, and we'll talk about that a little bit. Well, because people have shifted so much to natural cycle, but again, convenience for the clinic, convenience for the patient, if you're going to transfer 7 days after an HCG trigger, and you trigger on Saturday and Sunday, you're going to need to see the patient for monitoring on Saturday or Sunday, and you're going to need to do the transfer 7 days later on Saturday and Sunday. So again, the Shady Grove group said, well, what if if the patient has a follicle that's 17 millimeters or more on Friday, we'll trigger them, their transfers the following Friday. If their follicle is less than that, we'll treat them with GnRH agonist and 75 of HMG, trigger them on Monday, then their transfers on a Monday. So I can avoid the weekend. And what did they show? They showed in what they called their scheduled cycles compared to their natural cycles. This was not a randomized trial, so it looks as though it may be a little bit higher. There were a much smaller number in the programmed cycles, and again, it was not randomized. And you could sort of argue how natural of a natural cycle is this? But when my fellows and I started to kind of calculate what's the cost of bringing someone in for extra ultrasounds and monitoring versus the cost of 3 days of GnRH agonist and 75 of menopur, it wasn't necessarily more expensive, which I thought it might be. But maybe the other thing to do is to just improve the convenience. Why do I have to wait till the follicle's 17? Back in the old days, we wanted it to be at least 18, but maybe I don't need that. Maybe I can trigger as soon as my endometrium's at least 7, and my progesterone's less than 1.5, so I haven't had an endogenous ovulation, and regardless of what the follicle size was. And in this study, they showed no difference between a diameter of 13 and 22, but I would suggest to you that there was a wide confidence interval for those that were less than 15, and so I think we have to be a little bit cautious. And also that in those patients where the diameter was 13 to 16, they were still an average length of 10 days, and their estrogen was 219. So if we're going to say you need at least a 10-day, if the follicular phase matters, maybe it's not the size of the follicle, but it's the exposure to estrogen and it's the length of time. They were all treated with vaginal progesterone twice daily, starting 2 days after HCG. So in summary, from the US perspective, we still believe intramuscular progesterone is the way to go, at least every 3 days. And I think it probably is not just that direct first pass uptake of the endometrial progesterone, but also those systemic effects decreasing contractility of the uterus and decreasing the immune response. For natural cycles, it looks like there's no harm to give luteal phase vaginal support for everyone. You would think that if I triggered with HCG and I had a corpus lutein, I wouldn't need to also give the vaginal progesterone, but trigger with ovulation, allow a spontaneous surge. You do have less visits if you trigger. I would suggest that there are remaining questions, at least I still have remaining questions. How important really is the follicular size, and was that 18 a surrogate for these other markers of estrogen levels and things like that? And if we want to try to not have to measure blood levels to make it more convenient, maybe I need to have a certain follicle size. If you do trigger with HCG, do you really need to also give supplemental progesterone in the luteal phase? And if you are going to start progesterone, when should you start it? And most importantly, when should you start it to eliminate the need to measure blood levels to get to that mythical, it has to be over 3 by 36 hours to say that it was really a surge. So I think we agree more than we disagree between the States and Europe. We agree that preparing the uterus is a hormonally driven phenomena. I agree, progesterone's the key, but progesterone can only act on an endometrium that's been prepared by estrogen. And so what is our monitor of that progesterone, of that estrogen receptivity? And I'll stop there. Thank you.